We're going to get started. Good morning, everyone, and welcome to Grand Rounds. Today, our speaker is Dr. Robert S. Brown, Jr. Dr. Brown is the Vincent S. Astor Distinguished Professor of Medicine and the Chief of the Division of Gastroenterology and Hepatology at Weill Cornell Medical College in New York City. He received his MD from New York University and an MPH from the University of California, Berkeley. He did his residency at Beth Israel Hospital, Harvard Medical School, and a fellowship in gastroenterology and hepatology at UCSF. He has co-authored over 200 peer-reviewed articles and is the editor-in-chief for liver transplantation. Dr. Brown has also received the Young Investigator Award from the American Society of Transplant Physicians, the Senior Attending Teaching Award at Columbia University College of Physicians and Surgeons, and the American Liver Foundation New York Chapter Physician of the Year. So you guys could join me in welcoming Dr. Brown. Please note that our CME information will be provided during and after the presentation, and there will also be 10 minutes at the end for questions and comments. Thank you.
Well, thank you for your kind introduction. It is my pleasure to be here. I wish I could be there in person, but at least virtually to join you, Nick, Zaid, Kaveh, and all of the rest of you for this presentation. These are my disclosures. And here is your CME information. So we're going to talk today about hepatitis B. I think one of the most interesting viruses around in that it lives with us almost like a commensal. It is a partially double-stranded DNA virus with multiple overlapping reading frames, which makes it one of the most efficient viruses possible. It also, as you can see, it exists in multiple forms. You have both intact virions as well as just proteins that are transcribed off the DNA template, which produces both free S and free E antigen that probably provides some type of viral suppression of immunity and tolerance. When we think about the epidemiology of hepatitis B, this is a highly efficient virus. It is much more infectious than HIV, and the only thing that prevents this from being even more of a problem worldwide is that when adults are exposed, the majority of them will clear it. So of the 2 billion people worldwide who have been exposed to hepatitis B, only a small proportion carry it, 400 to 800 million people, but that is an incredibly large denominator. That makes hepatitis B, because of its risk of developing liver cancer, the second most important carcinogen after tobacco. And as tobacco sales are declining, we'll see whether Hep B vaccination, which is probably the first real anti-cancer vaccine, will keep up and reduce that cancer risk. In the US, about 2 to 3 million people have chronic hepatitis B, making it probably the fourth leading cause of chronic liver disease behind alcohol, non-alcohol related liver disease, and hepatitis C. But in immigrant populations, particularly those from East Asian and Asia Pacific Islanders, we see very high prevalence. But we also see high prevalence in immigrants from South America and elsewhere. In the US, if we look at people who acquire hepatitis B here in this country, the prevalence looks like a sexually transmitted disease, in which very low rates in young individuals, rising through teen years, peaking at age 20 to 29, and then declining, likely due to acquisition of immunity or transitioning out of a high-risk group through monogamous sexual behavior. But in reality, this is two diseases based on when you're exposed. So the majority of chronic infection actually comes from perinatal transmission, where the likelihood of chronic infection is over 90% if you're exposed in the first year of life. This rapidly declines to the point where at age 8, you are only about 5 to 10% likely to have chronic infection. But at all of these ages, you are very unlikely to have symptomatic infection. It peaks in adults at about 40%. So the majority of people who've cleared hepatitis B never knew they had it. And the majority with chronic infection don't know they're chronically infected unless they are screened. So when we look, when we look at the global prevalence of hepatitis B, you can see that we are in a low prevalence country here in the United States, but that most of Eastern Europe, Asia, Africa, and parts of South America are high prevalence. And so it is estimated that we have to screen from any place that has a prevalence greater than or equal to 2%. So you can either memorize the map or view that anyone who is foreign born should be screened. Now, when we think about chronic hepatitis B, I told you that 90% of children, but less than 5% of adults will go on to chronic infection. And many of them will follow the classic path of all liver diseases, which is chronic inflammation, fibrosis, and eventually cirrhosis in a proportion, which for most chronic liver diseases is around, if you had to pick a number, 25%, partly due to the age of infection, partly due to the fact that some will have a benign course, partly due to the fact that some will die of competing causes. And once you have cirrhosis, you can develop decompensation. And in hepatitis B, the development of cirrhosis, as you'll see in a moment, is a bad prognostic finding. However, unlike all other liver diseases, patients with hepatitis B can go on to liver cancer in the absence of cirrhosis. So for all of our other liver diseases, we only screen for cancer in cirrhotic individuals. Unfortunately, for hepatitis B, all patients are at risk. And this is why for hepatitis B, unlike our other liver diseases, liver cancer occurring largely in non-cirrhotic individuals, because they're the majority of patients, is the leading cause of death. So how are we doing in hepatitis B? And the answer is, in our country, we're doing okay. You can see that between 1967 and 1987, there was a perpetual increase in the case rate of hepatitis B. The first licensed vaccine came out right around 1980. And then a lot of things happened all at once. It's hard to know which is the leading, but I think it was probably screening of pregnant women and then immunoprophylaxis combined with efforts to reduce HIV transmission among men who have sex with men and healthcare workers, leading to a decline over time. You can see that we've done infant vaccination, though it is not a required vaccine since the 90s. Adolescent catch-up vaccination has been incredibly poor and under uptake. And I'm going to talk about vaccination later. So in the, if we think about transmission, most transmission occurs both vertically mother to child and horizontally in children, much of it related to contaminated needles that are used for medical procedures, including vaccination in some other countries. But if you look in the US at acute hepatitis B, this looks largely like a sexually transmitted disease. You can see that sexual contact, household contact, men who have sex with men, multiple sex partners and unknown are the leading indications for transmission. And injection drug use, which is the leading etiology behind hepatitis C, is seen in the minority. And the reason for this difference is, though this is a bloodborne illness, it is also present in other bodily fluids, unlike hepatitis C. So this can be transmitted both sexually and bloodborne, but it is important to know that this is not present in breast milk, and thus we do not have any reason that women with hepatitis B cannot breastfeed their children. once they get immunoprophylaxis. And this is not transmitted through casual contact. So let's start with screening. And this has been the list of screening that is recommended. And you can see it includes both people born in high endemic areas, as well as children of those born in high endemic areas, household and sexual contacts of anyone with hepatitis B, people who have ever injected drugs, people with multiple sexual partners, men who have sex with men, anyone who's been in a correctional facility, anyone who has elevated liver tests, anyone with HIV or hepatitis C, anyone who's on dialysis, and all pregnant women with every pregnancy. The CDC is now toying with the idea of universal screening. I look at this and I say, it's not a huge jump to get from here to universal screening. So if you want to be ahead of the curve, start universal screening today. And what universal screening is, I've shown you all these hepatitis B tests, and there is differences on what people have to recommend screening. There is only one test for hepatitis B for screening, and that is the surface antigen. Many recommend getting what they call the triple screen, which is surface antigen, antibody to S, which is what you find with vaccination, and antibody to core, which is what you have with natural infection. It is important to remember that E antigen and anti-E should only be tested in people who are surface antigen positive. Do not use these for screening. So for screening, it's surface antigen, core, and anti-S. And what you can see is the screening algorithm for hepatitis B is quite easy. Surface antigen is all we need to know whether they have hepatitis B. If they're positive, you can then work them up, and I'll show you how to do that in a moment. If they're negative, the only purpose to checking core and anti-S is to vaccinate. If they're positive, meaning anti-S is positive or anti-core is positive, you can see in this guideline, they only recommend S. But given that the prevalence of core in our society is about 30%, I would recommend both. If either is positive, they're immune. If both are negative, vaccinate. So we have someone who's surface antigen positive. What is the next step in their evaluation? And the first thing is the ALT. Now, ALT has been recommended to be used for screening for treatment, but it is important to remember that we need to lower the upper limit of normal when evaluating hepatitis B. The upper limit of normal, which in some labs goes as high as 50 to 70, includes people who are obese, who are diabetic, and probably have fatty liver. And so we have been trying to harmonize where we view the upper limit of normal, because above the upper limit of normal is a trigger for treatment. And if we include people with signs of underlying liver injury, it will be abnormal. And if you look at people who do not have fatty liver and don't have any liver disease, 90% will be below 35 in males and below 25 in females. So when we look at what twice the upper limit of normal is in the guidelines, that should be about 50 in women and 70 in males. So the next thing we have to do is look for other bloodborne viruses. And HIV and hepatitis C will be present in somewhere between 10 and 15%. It depends a lot on the population studied. Hepatitis D, which is a virus dependent on hepatitis B, it can only be seen as a co-infection. It's prevalent in Mediterranean, South American, and now we're seeing Eastern Europeans. And it is debated whether everyone should be checked for D antibody or only selected individuals. Part of that is because we have had no real effective therapy for D besides interferon. I have started to do screening of all my patients, though that is still controversial. And then finally, hepatitis A immunity should be checked for, a hepatitis A total because it is recommended that anyone with chronic liver disease be vaccinated for hepatitis A if they are not immune. So when we think about complications of liver disease, we need to prevent both fibrosis and cancer. And because cancer is the leading cause of death, it makes treatment more controversial. Because if we were only trying to prevent cirrhosis and only cirrhotic patients developed cancer, the treatment algorithms would be relatively easy. You would only have to treat those with a progressive fibrosis. But because those particularly with high viral load, can go straight from no fibrosis to cancer, the treatment becomes more complicated and linked to the risk of cancer. But it is important to note that once you develop cirrhosis from hepatitis B, you're in bad shape. Even if you maintain compensated cirrhosis, there is a high mortality because the risk of cancer in cirrhotic patients with hepatitis B is extremely high. With antiviral therapy, we can likely prevent decompensated cirrhosis, but it does not appear that we greatly reduce the risk of cancer in the cirrhotic individuals. So we have to both really prevent cirrhosis and two, prevent cancer. But fortunately, we know that hepatitis B viral load, unlike that of hepatitis C, is critical in terms of the risk of developing both cirrhosis and cancer. So it is actually the single most important prognostic feature. And so we need to quantify viral load to both monitor disease activity, to figure out whether people are on need treatment, and obviously to monitor them on treatment. Now, it is important to know that these reports can come in either copies or IUs. And the only reason that's important is that one copy is 5 to 6 copies is one IU. And so when you look at the old literature that uses copies and want to bring it back to IUs, you got to divide by 5. And so this is the REVEAL study, which was one of probably the only natural history of untreated hepatitis B. And this was a cohort that was then followed for multiple years with blood at entry, young individuals. The median age was in the 20s. And then you can see that over the next 10 to 15 years of follow-up, these young individuals, mostly non-cirrhotic, had significant, I would say for such a young age, mortality. And that the cutoff in this was at about 100,000 copies, which would be 20,000 IUs per ml. And that those two groups above 20,000 had a close to a 20% mortality in those 10 years of follow-up. And that when they did multivariate analysis, largely this was related to a high rate of HCC. And you can see that 20,000 copies or 20,000 IUs, 100,000 copies or more, had a rate of cancer of 1 to 2% per year in this very young cohort followed over time. But you can also see that this blue bar had an intermediate risk, and this is 2,000 IUs, and this is why it's been a group that has more controversy. But even those with an undetectable viral load have some risk, though this was 1% sort of per decade rather than per year. So how I said earlier that we have to both look at viral load and ALT. And the answer is that ALT is an important criteria, both because it is associated with an increased risk of complications, but more importantly, if you want to do non-permanent therapy, meaning being able to stop therapy, it is the most important predictor of the likelihood of E antigen seroconversion in patients who have E positivity. So if you don't want to treat forever, an elevated ALT predicts a higher likelihood of response. And as I discussed, we're going to use the new normals. Now, historically, the next step would be a liver biopsy. And I believe, and we can discuss it if you wish with Nick during the discussion period, that I no longer use liver biopsy for staging of anything, really. I use non-invasive markers of staging. They're both serologic markers and elastography, but we can monitor for progression serially, much better with non-invasive markers. And we can use these to replace liver biopsy. And so fibrosis staging really should be done at entry, and then in untreated patients serially, certainly by at least age 35 to 40. But what I do is I use it over time to assess progression of disease. Now, when we talk about liver cancer screening, there are two tests that are commonly used, either alone or together. If you're going to use them alone, ultrasound is the only single test because its sensitivity, specificity, and diagnostic accuracy are much better than alpha-fetoprotein, because alpha-fetoprotein can be normal or near normal in up to 40% of patients who have cancer. However, because alpha-fetoprotein is significant in terms of its positive predictive value, I like to do both. The screening has been shown to improve outcomes, to identify smaller tumors, which have a higher curative rate with either resection, ablation, or transplant. And so everyone agrees that you should screen with ultrasound, I'd say with alpha-fetoprotein, an interval of 6 to 12 months. 12 months has been shown to improve survival. 6 months has been shown to find tumors at an earlier rate. So at least once a year, preferably twice. The only question is when to start, and that has been controversial, and I'll address that at the end. So I told you that in patients who are surface antigen positive, we need the DNA and we need the E antigen and E antibody. And with that, we can classify them into stages and decide on treatment. For patients who do not have cirrhosis, who are E antigen positive, we use the ALT and the HBV DNA. And everyone agrees if the ALT is twice normal and the viral load is above 20,000 IUs, that would be our old 100,000 copies, we're going to treat. Most people agree that if they are in what we call the immune tolerant phase, which is the early phase with a normal ALT and a high viral load, that we should consider monitoring, though there are people who have been moving to treating everyone above 20,000. And in between, we have this sort of gray zone where some people think that they may be seroconverting and we can monitor them. Now, if anyone has significant fibrosis or cirrhosis, we need to treat all. So for E negative patients, some people use a lower viral load cutoff of 2,000 IUs because the risk of significant disease is higher. But then once again, the same algorithm. If the ALT is elevated and either the viral load is positive, or some people say viral load positive or fibrosis, that you're going to treat and then monitor them for response by checking for viral suppression either every 3 months or every 6 months. And the goals of therapy is to decrease the risk of progression to either cancer or cirrhosis. And this last therapy I'm going to talk about later, which is to prevent mother-to-child transmission, which involves third trimester therapy for women with even higher viral loads, 200,000 IUs per ml. And the goal of therapy is to suppress viral load or achieve what we call functional cure, which is surface antigen loss and surface antibody. Now, when we talk about treatment, we talked about the goals, and the therapy is now recommended for anyone with immune active disease, meaning they have cirrhosis with any viral load. Now, immune tolerant hepatitis B is the patients with very high viral load and a normal ALT. If we do non-invasive tests, they have really no fibrosis. If you do a liver biopsy, they show minimal inflammation. And this has been a controversial group because they have a high risk of cancer, but we have very little data on therapy in this group. And we know they will not seroconvert with therapy. So once you start therapy, therapy is likely lifelong. So when we think about treatment of immune tolerant disease, there are different recommendations for therapy. Some say treating patients who have fibrosis. Some say start treatment at age 30 to 35, or if they have a family history of liver cancer or cirrhosis. So what to do with the immune tolerant patients? Most people agree that you give them some time to become immune active, provided their non-invasive markers are negative, and then only treat them if they either have fibrosis or they remain immune tolerant into their 30s. Now, what about treatment during pregnancy? This is now recommended to reduce mother-to-child transmission in patients who have viral load above 200,000, because it's been shown that 10 to the 6th to 10 to the 8th are the cutoff at which immunoprophylaxis fails. The only therapies that have been studied are lamivudine, telbivudine, and tenofovir. In the guidelines, we recommend tenofovir because of the lower rate of resistance. Generally started at 28 to 32 weeks and stop not at birth, but in our guidelines, 3 months postpartum, because most of the flares occur 3 months in the first 3 months after delivery. If obviously they meet standard criteria for treatment, you treat anyway. And regardless of whether they have a negative viral load or not, with or without therapy, all infants of surface antigen positive women should get hepatitis B immune globulin and an accelerated Hep B vaccination starting at birth. And the reason for this recommendation was initially we told people that the risk of transmission was 5%, and some people felt that that was acceptable. I never did. And then it was shown that if you were under 6 logs, the risk of transmission with immunoprophylaxis was basically 0. And in e-antigen negative, also 0. But it rose between 6 logs and 8 logs up to almost 8%. And so we decided that the cutoff in the US guidelines should be 0, that this was a preventable illness, and thus we chose 6 logs as or 200,000 IUs as the cutoff. Others have chosen 8 logs or 2 logs higher. And that's because you can see that in both the intent to treat and the per protocol analysis, meaning those that got all of their prophylaxis, that unfortunately the numbers disappeared. I can tell you this is 0 in the per protocol analysis, 5% in the intent to treat, compared to 7% and 18% in the placebo arm failed immunoprophylaxis. And you can say, why did intent to treat higher? Because not everybody completes their 3-dose vaccination for hepatitis B. But you can see that in both groups, TDF reduced the rates of vertical transmission. So TDF is also one of the 3 first-line options for hepatitis B in general, and that is why it replaced lamivudine in our pregnancy recommendations. You can see that for oral therapy, there's 1 nucleoside, entecavir, and 1 nucleotide, tenofovir, which has 2 forms, tenofovir alafenamide or TAF, and tenofovir difumarate, 2 different prodrugs of tenofovir. And these have high potency and high genetic barrier to resistance. Lamivudine, adefovir, and talbivudine are no longer preferred because of the rates of resistance with these drugs and really should not be used in virtually any circumstance. Pegylated interferon is among the preferred agents, but cannot be really used in cirrhosis, and most people don't use it anymore. I don't use it except for hepatitis B and D co-infection, where we have no other options. Now, all of them are renally excreted, and so all of them have issues with creatinine clearance. For entecavir and tenofovir difumarate, they have to be dose reduced starting at a GFR of 50 mils per minute. For tenofovir alafenamide, which is a more effective prodrug with a lower serum level and higher liver levels, no dose adjustments need to be made till 15 mils per minute. There is no recommended dose between 15 and the use of HD for TAF, unfortunately. So in that group, you may need to switch back to TDF once a week until they're on dialysis. Now, TAF and TDF are different in the way the prodrug is, and thus in how much serum exposure and thus how much nephrotoxicity there is. And so you should use either entecavir or TAF rather than TDF, certainly in people over age 60, those with any history of bone disease or high risk of bone disease, and those patients with any degree of renal impairment. How to choose in between the two in that group of patients is based on either any prior lamivudine exposure, HIV, HBV co-infection where entecavir doesn't work, or if you're concerned about dose adjustment right around the creatinine clearance of 50. Entecavir and TDF both have a generic. TAF does not, and so if there's a generic plan required, certainly entecavir or TDF is preferable. In everyone else, it's really the choice of the clinician. I think you have 3 therapies, they all work well, and they're all safe. So we start the patient on therapy. Our goal is to make them undetectable. What happens when they have low-level virus, but don't become undetectable? And this is common. Usually it's a very low level, sometimes just not quantifiable, but detected. It used to be that this required a lot of thought and combination therapy, but we're at the current time, actually, most people recommend, as long as it doesn't plateau and begin to increase, that you should ask them about compliance. For entecavir, which is required to be taken on an empty stomach, ask about dosing. For TAF, which is required to be taken with food, ask whether to take it with food. TDF, it doesn't matter, but we don't have to do combination therapy for low-level viremia. Rising viremia should concern you for resistance, particularly with entecavir, and consider either switching or adding. The hardest thing in hepatitis B therapy is when to stop. And nobody knows the right answer. We'll talk about e antigen loss and seroconversion. Some people believe you should suppress viral load forever, or some say for a certain period of time. And then everyone would agree if you achieve S antigen loss, which we call functional cure, you can stop therapy, but this is the minority of people. So if you choose surface antigen loss as your endpoint, indefinite therapy will be required in over 90%. If for the other endpoints, it can be anywhere between 20 to 40% and maybe up to 60% can come off therapy. Certainly anyone with advanced fibrosis or cirrhosis need indefinite therapy. And because long-term therapy is the rule, certainly at least 5 years of therapy for most. You need to select your patients who are going to be compliant and educate them on the importance of compliance, because non-compliance and stopping therapy can be associated with flares, reactivation, and liver failure. So the big question is, in patients who are e antigen positive, who convert, meaning they lose e antigen and they develop e antibody on nucleotide therapy. Obviously, interferon is limited therapy in all. And the guidance is divided. Most people say you can consider stopping therapy with a period of consolidation after e antigen seroconversion of at least 12 months. For APASL or the Asia Pacific, they say 3 years. The US and Europe say 12 months. I pick the Brown recommendations is right in between, 2 years, because 2 years has been shown to be superior to 1 year, and you can give them a period of time to see if they might lose surface. So how many people does this apply to? And you can see that whether you use interferon, entecavir, or tenofovir, at about 5 years of therapy, somewhere between 20 and as high as 40% may lose e antigen. But if we look at that functional cure on the bottom, you see that the rates of S antigen loss are extremely low, anywhere between 1 and 8% in the various studies. Now, obviously, for the E negative, there is no chance for e antigen seroconversion. They already have seroconverted, and they have a mutation that allows the virus to replicate. And so you can see that almost none of them will lose surface antigen over a 5-year period, and that makes stopping therapy difficult in this group. So when we look at e antigen loss and then relapse to high viral load, you can see that less than 12 months, almost nobody will maintain a response. But the older you are, and the shorter your period of consolidation therapy, the better. And so you can see that if you look at this group that was less than 40 years and had more than 15 months of consolidation, most patients maintain virologic suppression, which one should push us towards earlier therapy and longer consolidation. For E negative, the US tends to say treat forever or until they lose S antigen, which, as you can see, occurs in about 1% of patients, unless they say a compelling reason for treatment stopping. For the Europeans and the Asians, they say at least 3 years, some say 5 years, and then with close monitoring in those patients who don't have cirrhosis. And the reason behind that is this. So this is what generally happens when you stop therapy. Virtually everyone has a virologic reactivation. That's this dotted red line, which goes up and then can follow one of several patterns. It can go up and stay up. They can have an ALT flare with that, or they can have an ALT flare and then both the viral load and the ALT can settle back down to a lower level. And so if you look, some people, about anywhere between 20 and 30%, will have a sustained virologic response. 40% will require a pretty quick reinitiation of therapy, and then 10 to 20% are in the middle. And you can see that with that flare, there is a chance of losing surface antigen. And so some have said in patients who don't have advanced fibrosis, you can consider stopping with close monitoring. But if they have advanced fibrosis or cirrhosis, you have to treat indefinitely. I tend to treat until surface antigen loss because withdrawal is promising, but you need to really have very close monitoring. So that's a lot of stuff. How can you really remember all this if you don't see a lot of hepatitis B? Well, there is an app for that. I do work on the CME side with clinical care options, but I don't receive anything from the app, not a dime. But you can take a picture of this and you can put in the patient characteristics and come up with the guideline recommendations, and that can help you along since the ASLD guidelines are not interactive the way the Hep C guidelines are. Now, I told you what to do with the people who are on therapy. What about those that are not on therapy? And the recommendations were initially monitoring every 3 to 6 months. I would say I just do every 6 months for everybody. That keeps my cancer screening, my viral measurements all in the same token. So if you think about it, twice a year, what I say is see me once a year, see your primary care once a year, get these lab tests done twice a year, and obviously cancer surveillance. And the recommendations for cancer surveillance are, of course, we talked about what to do, but in who, it's anyone with cirrhosis, anyone with a first-degree relative with a history of HCC, at the time that you first meet them, no matter the age. And then Asian and Black men older than 40 and Asian women older than 50 is when the recommendation of age-based screening begins. Other people choose younger, but that's where the guidelines are. Now, finally, I want to turn my attention to vaccination. And this is also something which is under flux. The ACIP is considering universal adult vaccination for people who did not get childhood vaccination. But the current recommendations are that anyone who lives in a house with somebody who has hepatitis B, any healthcare worker, people who have sex with more than one partner, people with end-stage kidney disease, anyone who's going to travel to a place that's high, that's most of us, anyone who wants it, people with HIV or other sexually transmitted diseases, men who have sex with men, injection drug users, and all newborns, and previously unvaccinated children and adolescents. This is about as close to saying, I believe in universal vaccination, but I can't say it. So I would say, like universal screening, we should move towards universal vaccination. And I'm hopeful that within this year, we're going to get to those two recommendations from most US organizations. Now, once you vaccinate, the question is whether you should test post-vaccination for antibody. Whether you use the old 3-dose vaccine or the newer 2-dose vaccine, 95 to 98% will develop immunity. If the patients who are vaccine non-responders, most people recommend not revaccination. I think our recommendations are going to go to universal vaccination without post-vaccination testing and without a booster. The only reason to consider post-vaccination testing is because we don't recommend booster, and we might recommend prophylaxis after exposure if you are a primary vaccine non-responder. So this is something that you can decide both for yourself if you get vaccinated, as well as for the people you vaccinate. So hopefully over this period of time, I've made it clear that this is a global epidemic of enormous scope. Though US is not an endemic country, immigration makes this something that everybody needs to be concerned. Most cases are underdiagnosed, which is why universal screening is so critical, because hepatitis B can progress silently to either liver failure or liver cancer without developing advanced liver disease, thus no signs that the patient is progressing. Routine screening for hepatitis B with the triple screen can produce vaccination and save lives. And obviously, the management of hepatitis B does involve ongoing monitoring, decisions on therapy, but the therapies are actually really quite easy. We have two single pill oral nucleoside therapies that have minimal side effects and are highly effective at suppressing virus, though the endpoints of therapy are not exactly clear. I hope this has given you an introduction to hepatitis B that has been useful for you. I've given us at least 10 minutes for questions, and here's your CME information if you wish it or need it. Thank you all for your attention, and I'll take any questions.
Dr. Brown, thank you very much for this review and really a complicated topic to think about. Thanks also for that online app, which I think is something that really be very useful for people to really think about and understand, treatment and testing options. So while we're waiting, and we'll get some questions in the chat. Please put those in there. Let me just go back to something, it was very interesting, that, and you highlighted on your slides that age matters in terms of treatment and other issues. Why is that such an issue? Is that because of immunocompetency as a function of age, or if you've had, this Hep B for longer periods of time, there are deeper reservoirs? Why is age ends up being such an important discriminator?
I think that it's both. I think we know that younger individuals are more immunocompetent and probably have had less time for the virus to tolerate, but it's probably also a cohort effect, meaning that the people who are immunologically able to seroconvert on their own have been weeded out by the time you treat at an older age. So some of the people you treat at a younger age might have seroconverted on their own, and you just accelerate that process with therapy. And others, you may promote a higher degree of seroconversion. And this has been shown in the, remember now we don't have any placebo-controlled trials of treatment, but lamivudine was tested against a placebo. And what you saw was if you had a high ALT flare, you had a pretty high rate of seroconversion on placebo, about 30% if your ALT was 5 times the upper limit of normal, so about 200. But with drug, that rate rose up to 70%. So I think there's two elements. One is when you take and start treatment in older individuals, the ones that would naturally have a flare with seroconversion, which could be up to 30%, have been weeded out. And two, you probably have larger amounts of what we call cccDNA, or closed covalent circular DNA, which provides a reservoir for reactivation when the therapy is stopped. So I do see two questions in the chat box.
I'll just go through that. So because not everybody has maybe has the chat. So we have some from our ID folks here, and Dr. Della Piazza says, with respect to hepatitis surface antigen to hepatitis surface antibody seroconversion, since it is so very rare on treatment, how frequently do you test for seroconversion for patients on chronic therapy? Also, what are your thoughts about vaccinating patients found to have isolated positive hepatitis B/C antibody?
Both really excellent. Both really excellent questions. So for surface antigen seroconversion, I test once a year. Because the tests are cheap, some people just throw them in on their every 6-month monitoring just to make it more practical so that you don't take longer. But to me, since it is so rare, I test for it once a year. Remember that though DNA is a pretty expensive test, surface antigen, surface antibody have a cost of about $7. So I find it's easy to do those once a year, surface antigen, surface antibody. But remember, this won't occur if they're not suppressed. So I see people who still have a high viral load being tested for seroconversion. That's not going to happen. So this is only a test you should be doing, looking for seroconversion, either from E antigen positive to E antigen negative, or surface antigen positive, surface antigen negative in patients who are suppressed, because otherwise it won't happen. And then in terms of anti-core means that they had hepatitis B and they cleared on their own, which means they had surface antibody at some point and it waned. And most people recommend that no booster is needed because, one, they've cleared it. Two, if you give the vaccine, you get an amnestic response. In the guidelines, it does say that you can consider boosting people who are either HIV positive or immunosuppressed, though the data to support that this is needed is really small. I personally, in my practice, don't boost anybody because if you think about patients who are going to get immunosuppressed, those surface antibody is somewhat protective. It is not completely protective. And so if you're going to give people who are at prior B and a core positive need a bone marrow transplant or lymphoma treatment, you're going to give them prophylaxis regardless of surface antibody. And so I don't feel it's that useful to boost, though some would say that it is certainly reasonable in those patients who either have immunosuppression or will be immunosuppressed in the future. For example, someone on the waiting list for a kidney transplant.
So thank you. Also from infectious disease, Dr. Varghese makes a comment that the general treatment of hepatitis B is unwieldy and a bit of a confusing landscape. She asked, do you know if there are efforts to make hepatitis B curable like hep C? Do you think that's possible? And what are the main stumbling blocks you see preventing discovery for cure?
So, hepatitis B, though it is not very much like hepatitis C, it's more like HIV. And, hep C has no DNA intermediary. It does not have a reverse transcriptase. And so it's a pure RNA virus. Hepatitis HIV obviously is a reverse transcriptase RNA virus and creates a DNA intermediary that integrates into the host genome. Hepatitis B has two DNA intermediaries, both its native closed covalent circular DNA and also integrates into the host genome. Now, we'll never be able to get rid of integrated DNA, but if you can get rid of CCC DNA, you can achieve what one would call functional cure, which will probably be durable. And there are efforts with, for example, RNA, small RNAs, and other techniques to try to reduce CCC DNA. The problem is that most of our therapies, which block the polymerase activity, do not get rid of CCC DNA. And thus, this is going to be a difficult bar to reach. So I think what I tell my patients is therapy is for the foreseeable future with the hope that medical technology will get there. But I'm a lot less optimistic because, we don't cure varicella. We don't cure any DNA viruses at the current time. And so I think it's still a world away, but maybe some type of intracellular DNA, focused DNA cleaving may be a way to do it, or immune stimulation.
Thank you. From Dr. Crow, one of our oncologists, notes that for patients receiving rituximab or other similar therapies, the recommendation is to give prophylaxis to anyone who's core antibody positive, even if surface antigen negative. What's the rationale for that?
So remember that everyone who is core positive has CCC DNA in their liver, and that will try to be both transcribed and translated and has the potential for reactivation. However, the immune system keeps it in check. And with intense immunosuppression, including really both T and B cell elimination, you can see reactivation from the isolated core state. And that's why only in those circumstances do we recommend prophylaxis for core positive. And Rituxan seems to be one of the major risk factors for treatment, though isolated Rituxan therapy without, treatment of a hematologic malignancy is much less common. So the current recommendations are bone marrow transplant, which involves, sort of complete ablation of the bone marrow, and Rituxan-based therapies for hematologic malignancies get therapy for core. Everybody else, any other immunosuppression is restricted to surface antigen positivity with or without DNA positivity. And part of that is because though reactivation is relatively uncommon in this group, the outcomes are terrible. Because without immune control, many patients develop this viropathic fibrosing cholestatic hepatitis, which leads to liver failure. And since most of them are being treated for malignancy with no transplant as a backup, death is common.
Thank you. We do have a couple of questions, but I do want to come back to Dr. Versopoulos and ask, Nick, any comments or questions?
Oh, I think this was a wonderful talk and wonderful overview. And I agree once you mentioned the way we're staging patients regarding fibrosis nowadays. I'm not sure if liver biopsy is the best way to do it. And we do the same protocol over here with invasive testing, like the PIB4 or with the FibroScan as well. And we'd like to thank you very much for agreeing to participate in our morning lectures, Bob.
Do you want me to take Zaid's question and then call it a day?
Yeah, why don't we take Dr. Fesch's question? So he knows that for patients with low-level viremia are at high risk for flare. Is your approach different? Would you recommend double coverage in this patient population as opposed to other patients with low-level viremia on therapy?
That's a great question, Zaid. I think the answer is I divide low-level viremia into two groups. One is those that are unquantifiable, but it says less than whatever your cutoff is, 40, 200, detected, meaning that the qualitative test is positive, but it's too low to quantify. And those tests are easy. Ignore them. I wish we would get that out of the report and it would just say less than 40. I just don't know what to do with them. They fluctuate on and off. They may reflect tiny levels of virus. They may be false positives. I don't know what to do with them. I ignore them. For other patients who have low-level viremia that is quantifiable, the first thing I do is I always repeat it. And oftentimes the repeat is negative. I would say that if you have somebody who is persistently low-level positive, to me, it depends on the therapy chosen. If they are on entecavir, I do tend to switch them to tenofovir for two reasons. One is prior exposure to lamivudine, which is a risk factor for entecavir resistance, may be hard to suss out, particularly in those that are foreign-born. Two is that entecavir, which requires an empty stomach for absorption, is challenging for some people, and they may have inadequate viral antiviral therapy levels. Tenofovir has also been associated with no resistance in up to 8 years of clinical trials. So for that reason, I might switch. I don't use combination therapy really in any patients anymore. I used to use a lot of it, but the data that supports that adding a second agent and its cost to the current therapies is pretty low. Though I think in a patient who's at very high risk, certainly no one would critique you, but I don't think the data to support that decision is really there. And then finally, I think most importantly, ask about intermittent non-compliance, which certainly happens, and make sure your patients understand that intermittent non-compliance is the major risk factor for the development of resistance to any antiviral, which I believe resistance can occur to any antiviral with enough pressure on it, usually for hepatitis B due to not taking the medicines.
Dr. Brown, I think we'll have to call it a day here, and I want to thank you very much for really a tremendous overview and review of hepatitis B. Certainly a lot of food for thought in terms of screening and treatment, vaccination. So thank you for all of that. And Thank you all for who joined this morning, and I'm sure you found it also extremely informative. So I want to wish everybody a great day, and thanks again for this wonderful presentation.
Thank you for having me.
Thank you.